Hi there, this is Tony, and I'm going to go over the stroke assessment using the assessment sheet for EMS 60. The 6 basic tests of this screen, and there are many that can be done, narrowed down to 6 tests that can be done in pre-hospital that cover the Cincinnati and LA stroke scale pretty well, are facial symmetry, upper motor, lower motor, proprioception and pronator drift, slurring of speech, which is kind of a motor for speaking. Then there is the Wernicke's and Broca's area of speech, which is essentially the ability to understand and repeat what is heard. And so the facial symmetry is pretty easy. You have the person, if they're in a good mood or cooperative, you can ask them to smile or just show their teeth. And you're looking for, again, asymmetry from one side or the other. And if it's, for example, in a stroke, you should be able to see wrinkling. Regardless of this side of the face, you see wrinkling there. If it's Bell's palsy, then you would, for example, see just smooth on that one side of the face and no other findings in the rest of the body. So that's a factor, and I expect if I see asymmetry on one side of the face, they're almost always slurring. And that is natural because the muscles that control the throat and face are all affected, and that would affect the ability to speak clearly. However, the person would be able to speak, or at least they're putting things together in the right way, and you can usually tell. Slurring is obvious immediately when you go on a call with a stroke patient. You almost don't have to ask about slurring; it just you hear it right away. Or the people who called you will be able to tell you their speech has changed. Upper motor is the standard is going to be grips. Normally, you just give them, a couple of fingers or one finger to have them squeeze, and you want to ask them to squeeze and check for weakness on one side compared to the other. And if there is one side weaker than the other, you want to find out if that was new or do they have residual weakness from, say, a previous stroke. Lower motor is the same thing. You're looking for anything that's testing the feet, whether it's pushes or pulls or lifting their legs. Pedal pushes and pulls is easiest because lifting a leg strains the back, and a lot of people can actually cause pain and give a false positive for weakness. So pushing and pulling and touch sensation, because you're down there, you can ask that easily, is again an easy check, and you're looking for differences and if the difference is new or not. The subtle one is proprioception. So with the grips and pedal pushes, we don't care what the eyes are doing because these are strength tests. They're checking strength motor control. However, when we're talking about proprioception, we're looking at having the patient be able to basically keep their hands in front of them, for example, and to check upper motor neuron from lower, where it's supinating the grips or supinating the hands. Then you ask them to close their eyes, and they close their eyes in short order. They will either be able to keep their hands like this, or you will notice a drift, or they'll just drop, or it may go up. Okay, any of those findings is wrong. Why do we have them close the eyes? Well, proprioception is the ability to know where you are in space and time without having to see. So if I have to see where my hands are to keep them in place, but as soon as I close my eyes, I don't know where they are and they start to go all over the place. Well, this is a problem, a significant problem. It will not show up as a motor issue. I could have perfectly strong grips, but I don't have good control. Other subtle ways to check that, of course, you could do nose touching to your fingers back and forth and compare. That gets into more detailed assessment. You can play around with that in route, but it's not a part of this, again, this assessment in particular. So it's pronating and drifting. Pronating and drifting, or you could just have drift, drooping, or going up. Either one of those, any one of those is bad. The next was slurring of speech, which you already kind of covered. You would just be in your introduction or talking to the patient, pick up on that. So that doesn't need any further clarification. The really tricky one is in the patient who's not answering you in full sentences, or they answer in 1 or 2 or 3 word sentences. Basically, nothing that stands out. However, if you ask them to repeat a phrase, for example, you need to teach a video for class today. Sir, ma'am, I'd like you to repeat this phrase and repeat the phrase, I love teaching video classes. And the patient goes, I love teaching video classes. Good. That means they heard you and they can say what they want to say. If you said, for example, I want to go to the beach today, can you repeat the phrase, I want to go to the beach today? And the patient goes, I want to beach to class today. Okay, you're good. Okay, try it again. I want to go to the beach today. Always give them the second chance, because as students will show, they display signs of stroke every day in class when we're practicing this. Give them a chance to say it again. I want to go to the beach today. I want to go to the beach today. Okay. No, I understand you're trying to say it and the wrong words are coming out, and the patient oftentimes will be like, they're scared or they're nervous because they just realized that they can't say what they want to say. And this is a really scary position for a patient, because, well, imagine people can't understand you because you can't communicate. It's like you speak a foreign language to everyone else. No one understands you. And even worse, they don't realize you're speaking in a foreign language. They just think you don't make any sense, that you're altered. So that is a positive finding. Always with all stroke assessments, to kind of differentiate between, say, a TIA and an actual ongoing stroke, you want to reassess this during transport. You would reassess this and reassess this several times, as you would with a concussion, and see if they get better. One time I had a patient who would get better and then get bad again. Better and then get bad again. Literally 7 times they went essentially into a kind of stroke and then would come out of it. So technically those were all TIAs, but this was emergent enough that it required getting this across to the emergency department staff that this is not a TIA type of patient. And the next thing is, if you have a patient who can't get anything across and they can't communicate, try having them communicate by writing. Use them, confirm that they understand things like, for example, can you just tell them, would you hold up 3 fingers for me? And they can hold up 3 fingers. All right, this tells you that they're understanding you, even if what you hear is gibberish coming back. It is super important to make sure the patient knows that you understand. They can't communicate, that you're going to take care of them, continue on the rest of your assessment and reassessments, and then make sure any receiving staff understands the patient is not altered. They just have, essentially, in this case, expressive aphasia. So hopefully that sums it all up, and that'll conclude this presentation.